So before we get stuck into the Best Start in Life tool, I thought might be interesting just to have a quick overview of the health economics team here at PHE. So there's around 10 of us split between offices in York and London, and we've got two main objectives. One is to make the economic case for prevention, so that's kind of quite national work, and the second is to build capacity and capability within the healthcare system. So in terms of the things that I do on a day-to-day basis, my role is working on the prioritisation framework, which you may or may not have heard of. I'm also in charge of the health economics training programmes, which this webinar is part of, and I've been helping to get the Best Start in Life ROI tool up and running. So as Sal said, that was published a couple of weeks ago on the gov.uk website on the 8th of March, and it was developed by Opportunity Advisors, which is a commission provider being overseen by myself and a steering committee of PHE members and external people as well. So in terms of the context of that piece of work, obviously, as you're probably aware, the provision of 0 to 5 public health commissioning services transferred to local authorities in October 2015, and ensuring every child has a best start in life is one of PHE's priorities, so the health economics team are quite keen to do a bit of work in that space. The tool looks to help local decision makers understand how cost effective a variety of interventions are that are aimed at children aged 0 to 5 years and or pregnant women. And we hope that information can be used to help provide cost-effective services at a local level that provide good value of money. In terms of who might be interested in the tool, local authority users obviously, but they might also extend to CCGs, SDPs, and people within the voluntary sector as well. So moving on to the identification of interventions, I won't walk through the flow diagram on the left-hand side too much because it's quite in depth, but I wanted to show that just to show the depth in which we kind of looked into the literature for interventions to cover. So we started off with almost 5,000 papers which were screened at abstract stage, and these were assessed whether they were relevant to what we were trying to do. So in terms of included interventions, we included any intervention that was aimed at young children aged 0 to 5 years and or pregnant women. It had to be published in the literature post 2009, which was partly due to pragmatism and partly because we wanted kind of up-to-date information. And those studies had to be conducted in the UK, Ireland, Canada, New Zealand or the US, and they had to report economic outcomes that could be feasibly modelled. In terms of what was excluded, the main exclusion criteria really to draw your attention to is that we excluded things that were covered elsewhere, so covered in our other ROI tools, in particular the oral health tool. And there are a couple of nice ROI tools, the Children and Young People's tool and the Social Emotional Wellbeing tool that covered interventions aimed at children. So we didn't kind of want to duplicate those results. Interventions are those that are those with the best economic evidence in a form that can be modelled. So we don't think the tool is comprehensive and it doesn't cover everything. So there may be things out there that are cost effective, but we just couldn't find information on them. So at the end of that process, we were left with 11 interventions, specifically relating to breastfeeding and postnatal depression. The reason those two things were pulled out again was because those were the ones that had evidence upon them. So there were 11 interventions. Some of them were targeted, particularly at women in deprived areas for one of the breastfeeding interventions in underweight children. And some of the postnatal depressions were targeted at women at risk of suffering postnatal depressions. So I've presented the results there on the right-hand side. So you can see that a number of them are dominant, that is, being cost-saving and generating health, and the rest have been expressed as incremental cost-effectiveness ratios, which represent the cost per unit of health purchased. So there's a bit of a variety of results there. Something of particular importance to draw attention to is what were described as the basic versus the full postnatal depression interventions, which I'll cover now. In terms of the basic postnatal depression interventions, because of limitations in the data, the effectiveness of those interventions could not be linked to the number of cases of postnatal depression avoided. So that really limited us what we could do in terms of the analysis. So that limited to health benefits and cost savings to the mother over a single year, and no health benefits or cost savings to the child was included in those figures. So those really do kind of influence the ICERs that are produced at the end, and that's something that's important to bear in mind. In terms of the full postnatal depression interventions, this effectiveness could be linked to the number of postnatal depressions avoided. So it's a much more encompassing analysis, and we could model out further into the future to look at longer term cost implications and outcomes. In terms of the interventions, something else that's quite important to flag up is that some of them have very different timescales involved. So the benefits can range from between covering 1 year to a lifetime, and these often differ between the mother and the child. So it's important to try and factor that into your decision making as well. When we come on to see the tool, it does quite a good job of trying to flag up exactly what the timescale was and what benefits and things were included and what were not. So to try and overcome some of these issues around the basic and full postnatal interventions, there was something that was done was called break-even analysis. So in that, we tried to look and understand how many cases of postnatal depressions had to be prevented by the basic interventions in order for it to be cost-saving. So in simple terms, that's just setting up an equation to think about how many cases would need to be averted in order for that cost of intervention to be covered by the cost savings from the postnatal depressions avoided. Once you've got that, you can compare across the basic and full interventions to try and make some inference. So the analysis showed that the basic interventions tended to have a much smaller number of cases that needed to be avoided than the full interventions. So what does that tell us? That tells us that those interventions would need to be less effective in order to be cost saving. So while that's not a conclusive indication that they may have been cost saving, it does indicate that they were severely affected by the time scale that we could cover in our analysis, and there's good reason to believe that they possibly are cost saving if wider kind of implications could have been captured in the analysis. In terms of how the tool works, the user selects their geography and the interventions they're interested in. The user also has to specify the proportion of the target populations that would be routed to that intervention. The model uses the available evidence to model costs, cost savings, and health benefits to mother and children. And then the model also presents a variety of cost effectiveness measures for each intervention. There is some limited capacity to model packages of interventions, so the provision of multiple interventions at once and what that might look like. And the tool also provides some charts to provide visual summaries. The tool was published on the gov.uk website, and it comes alongside a report that covers a lot of the details that I'm covering today and gives some background to what was conducted. So that's well worth a read. So probably the easiest way to find that and all our resources is to Google public health economics, and you can find us. We should be near the top of the results, and that kind of provides you with access to all the resources that we produce. So now I'm going to switch on to a presentation of the tool. So the first thing you see when you open up the tool is our landing page. So again, links are provided to the two nice ROI tools there. Something else I'd draw your attention to is the feedback options. So there's an email option and a complete an online survey. So we're always very keen to hear how people are using them, whether they've got any feedback about whether tools are useful or kind of issues they've flagged up. So please do feel free to use those. There's a couple of tabs of information around kind of how the tool was constructed. And this tab shows you some of the information around the intervention themselves to give details on the intervention name, the eligible population, and there are links to the original papers themselves. So getting stuck into the tool, you can select a variety of regions to analyze. So it covers national, regional, local authority, CCG and STP footprints. So for the example today, I'm going to run it at national level. And so all the figures will relate to England. All these values typically can be overridden, so all the gold cells can be entered with new data if you are interested in different values from the default. Also at this stage you can begin to kind of hone your populations a little bit, so there's some information there around the target populations for the various interventions that you can alter and adjust to local interest. At this point, you can also select which interventions you're interested in. So these are selected via a drop-down box between yes and no. As I mentioned earlier, you need to specify what proportion of the population would be routed into that intervention. So as a default, I've entered 10%, but again, that's up to the individual based on kind of local information and local assumptions. So there's one tab for breastfeeding, and there's a second for the postnatal depression interventions. After those are selected, results are presented in the Results tab, which provides a selection of information both for the mother, the child, and then combined, providing information on the combined net benefit, which is the cost savings minus the cost of the intervention, and the combined monetarized quality gain, so entering a monetary value for the qualities. And finally, the incremental cost effectiveness ratio. As I mentioned earlier, there's quite a lot of information that's provided here alongside. So it tells you the number of women that have been had the intervention, the length time of the benefits for the mother and child, and then there's some more information there around what information has been captured in the analysis. Some of that information is presented for the postnatal depressions. In the case of the basic interventions, the analysis was a little more limited, so you don't get quite as many figures and results coming out at the end. There's also the possibility to model a second scenario, in which case you can start to think about an alternative situation, so you can playing around with the numbers. So in this case, I think that the costs from the literature may be too low, in which case I'll increase them 25%. And these results are similarly presented in the breastfeeding scenario 2 and postnatal depression scenario 2 tabs, which gives you the results presented in the same way. Additionally, there's also a packages tab, which starts to give more information and think across the scenarios. So with the breastfeeding interventions, you can compare the two scenarios. So this is the presentation of scenario 1, presentation of scenario 2, and then the difference between the two. There is also the possibility in postnatal depression to start thinking about multiple interventions at once, or packages of interventions. So for the full postnatal depression interventions, you need to start thinking around how you would like to present the results. So there's three options here. You can do cumulative, conservative, or average. So what these mean is cumulative assumes that different women have been allocated to each intervention, and therefore the results can be added together. Conservative assumes that the same women have been allocated to the same intervention, in which case you don't get double the kind of the benefits of that intervention. You get double the costs, but the effectiveness is limited at the effectiveness of the most effective intervention of the ones they receive, and the average is the average of those two. So from those scenarios, you can start thinking around a selection of results and start thinking about where kind of your local area might place in between the conservative and the cumulative approaches. For the basic postnatal depression, there's no option to do that because of the limited evidence again. And finally, there are charts here which present information in a visual way, which allow you to start visualizing some of the information. So that's where I'll leave it for the demonstration of the tool, which was a quick run through of all the different options you've got. And now I think we'll switch to some questions.
Thanks, Scott. That was very, very helpful. I've got a couple to ask you myself. The first one would be, how do you define women at risk of postnatal depression?
Excellent. Yes, thank you. So as part of the defining population stage, you are asked to define the woman at risk of postnatal depression. So I don't think there's a clinical definition of that. So within the tool, what we've done is to have as a default the proportion of women that actually suffer postnatal depression. But again, that's one of the variables that can be altered. So the default is 13%, but based on local information or kind of how you plan to potentially provide those interventions, you could alter that.
Okay, thanks for that. And also, why do I need to specify the proportion of the population that is eligible for the intervention?
Yes, so that's one of the things that is not pre-entered into the tool and something that the users have to do by themselves at the intervention selection stage. So as a default, I use 10%, but again, that's up to the user control. So the tool doesn't make any assumptions about how many women would actually receive an intervention. It does provide information on the target population, for example, women living in deprived areas, but it'd be somewhat inappropriate potentially for the tool to make assumptions about what proportion of those would receive an intervention. So that's up to the user. It's probably worth bearing in mind that those values don't actually impact upon the cost effectiveness results. They do impact upon the total cost and total savings and total quality gains via the number of women allocated towards that intervention. But the cost effectiveness results are typically ratios, so kind of adjust for that scaling factor.
Okay, thanks for that. We've got a question here via the health economics inbox. and it asks, how do you define a basic and full intervention?
Right, yes. So the basic versus the full is determined by the amount of evidence that was available within the literature. So in the full interventions, what was able to be done was to link the intervention to a number of cases of postnatal depression avoided in the woman that received that intervention. And from that, you can then model out significantly into the future. In the basic interventions, it wasn't possible to do that. It only reported figures in terms of health gain and QALYs. So we were unable to kind of model out into the future. So we've had to limit the basic interventions to a very short timescale that was covered in the original literature. So what that does is it really impacts on the results that you see. So those interventions typically have much higher incremental cost effectiveness ratios because they're covering a much shorter time span and don't capture some of the longer term benefits that might occur.
Thanks for that. Another question that's come in, it's regarding the percentage allocated. Other tools do, and it provides a useful guide. It tends to be a round number, but allows the user to better understand what is a reasonable guess.
So I think this refers again to the percentage allocated to an intervention, if I'm understanding the question correctly. So I think we felt that it would be inappropriate for us to just take a guess on that. It probably depends on the setup of the local authority or the person providing the intervention, and kind of what their aims and objectives are. So kind of this wasn't just an assumption that the health economics team has come to. So all our tools are built in conjunction with a steering group of expert users, and we do try and do a little bit of user testing as well, and that wasn't something that was flagged up as a potential problem. I think it is something that would be difficult for us to indicate, but it is fully editable in the tool, and so users can play around with numbers and see what kind of implications that has.
Cool, thanks for that. Another question we've got in via email, it asks, how does the ROI tool ensure that a local strategic approach is adopted to supporting breastfeeding rather than investment in standalone interventions?
That's quite a difficult question. I think the tool is not specifically designed to influence the broader question around breastfeeding. So what we've done is tried to present the best evidence on specific breastfeeding interventions, which can maybe kind of be entered in as part of a wider conversation around breastfeeding support and the benefits of breastfeeding.
Okay, thanks for that. A couple of other questions I have noted down here for you, Scott. What interventions are included in the NICE ROI tools?
Yes, so as I mentioned earlier, there are two potential NICE ROI tools that are useful for kind of services aimed at children. So they are the Children and Young People's tool and the Social and Emotional Wellbeing tool. In terms of the interventions included in those, I think the ones that are aimed probably most at the same target groups as this are around smoking cessation. So there are a number of interventions there that are covered. So they can be kind of looked at, and these should probably be considered as a kind of a complementary tool to this.
Thanks for that. And another question I have, what is included in the cost savings for each intervention?
Yep. So it depends on the intervention that is being discussed. So if we look at the results tab, they're typically quite good at pulling out what has been included and what has not been included. And similarly, in the accompanying report, there's plenty of details about what has been included and what is not. So things that may have been included are around cost savings, so avoided hospitalizations. There may be things around wider social care costs and things like that for postnatal depression avoided. And in some cases, it was able to model children out into the future, so kind of reductions in health and social care costs, education, and criminal justice spending. So there's quite a broad spectrum of things that could have been included in that, and the tool does indicate that. Unfortunately, it wasn't possible for us to pull that out across necessarily different budgets, so some of the numbers are just totals rather than divided across various budgets.
Okay, thank you very much for that, Scott. We've got another question here via the chat function, and they ask, are there plans for wider ROI opportunities regarding the best start in life? For example, smoking in pregnancy, or perhaps school readiness, or indeed other PHOF related outcomes?
So yes, I think we'd have liked to have included them, but basically we're limited by the evidence that's available to us. So within the report that accompanies this tool, we do discuss in slightly more detail around some of the interventions that we would have liked to included, or kind of topic areas we would have liked to included, but just weren't able to find the evidence on them in a robust form that could have been modelled. So we're kind of limited in that sense. We kind of have linked up with NICE as best we can to cover some of the smoking cessation, which may cover smoking during pregnancy, but we've been unable to cover some of the wider kind of FOF aspects, such as school readiness, I'm afraid.
Okay, thanks for that, Scott. Another question we've got in here asks, has any link been made with interventions under the oral health ROI, for example, supervised brushing?
So there's no direct linking between the tools per se, but they do sit together in our suite of ROI tools, which should kind of be considered alongside one another. So indeed, when you're thinking around the area in totality, it's probably worth looking at both the ROI tool for oral health and this one together.
Fantastic. We've got about 5 minutes left, so a few more questions can answer. I've got one more down here. Do packages need to contain the same number of interventions?
No, they do not. So the packages here relate to the postnatal depression interventions, which can contain up to 3 within the full interventions and 6 within the basic interventions. So the number can be edited based on the scenario. So removing the data from a line here would reduce the number of packages. So we can see we've got 3 and 2, and then you can compare across different scenarios with a different number of interventions and what kind of implications that has. So it's potentially quite powerful.
Thanks for that, Scott. And another question here, which links back to the question before, the last one I asked if there's links to support childhood obesity interventions from targeting maternal obesity.
Again, that's kind of one of the things that falls into the category there wasn't sufficient evidence in kind of an economic capacity to model sufficiently. So kind of one of the things we typically do in these situations is kind of flag where their evidence gaps are, and we try and work to encourage people to enter research and kind of evaluate these areas as best we can. But at the minute, unfortunately, we've not been able to pull anything out in that area.
Okay, thanks for that, Scott. A few more questions that we have here. Do cost savings mean that we could spend less?
Right, so the interventions do present combined cost savings or cost savings per child and per mother. These probably don't relate to what we would term cashable savings. So cashable savings would be ones that would lead you to spending less money. So there's a variety of reasons for that. Really, to be a cashable saving, the savings have to be sufficiently large and occurring in the right place within the healthcare sector to warrant a reduction in activity undertaken. Typically, that activity might continue to happen, but just kind of switched in a different way, or kind of one person takes the place of another. So the savings aren't likely to be cashable in total. But it's quite difficult to disentangle that without knowledge of the particular local healthcare systems, and that's something that maybe local users feel they can start commenting on once they've used the tool.
Great, thanks for that. Another question here: can I model areas that are smaller than my local authority?
So yes, you can. Again, population size is one of the fields that are entirely editable to an individual. So if the person knows the total population of that area and the total number of live births, then they can update the tool in that way to incorporate different population sizes, different area sizes. I'd probably flag a note of caution that if you kind of go down too small, there's a potential that population might be quite homogeneous and may differ significantly from the population that the intervention was delivered to. So I guess I'd just suggest a bit of a common sense check to try and make sure that the population that you're modelling is still relevant to the intervention being delivered, and vice versa.
Fantastic. Got another question here via the chat function. It asks, is there any guidance for ROI users on how to use the information to support decision making?
Not particularly within the tool. but there are various other health economics resources that do try and support the use of economic ideas and economic evidence at local levels. So I particularly draw your attention to the e-learning modules, which are available through the e-learning for healthcare website. So you can register on that website and undergo 2 half-an-hour economics modules that cover a lot of basic economics, but they also cover a little bit on the kind of the various cost effectiveness measures and how those might influence decision making.
Okay, I think that'll wrap up our Q&A session. At the moment, we've got a minute to go to the end of the meeting. Thank you for your questions, and thank you, Scott, again, for that good presentation.
Excellent. Thanks all for attending.